Dr. Manisha Nada has specially crafted this session, which is double trouble, where we have cataract and a coexisting problem. So you need to take care, you need to improvise your surgery, improvise your counseling, and improvise your patient satisfaction to have good results. And Dr. Manisha Nada will be taking over.
So the first speaker of the day would be Dr. Ashish. He's going to present the double trouble. Let's see what trouble he gets while he does.
Need to be very, very careful when we manage these patients. I'm Dr. Ashish Lal, and with me is my team who have prepared this presentation. The first and the most important thing is that uveitis means a red hot eye. So don't touch a red hot eye unless it is cooled sufficiently. So whenever you want to go intervene, the eye has to be cooled up. So important thing is, do you have a uveitis? What kind of uveitis it is? Is it anterior, intermediate, or posterior? Do a good indirect ophthalmoscopy with indentation to rule out pars planitis and any specific lesion in the posterior fundus. A good slit lamp examination to rule out cells, flare, and any fresh KP. So you need to know whether there is a fresh inflammation going on or the inflammation is inactive. You can also find some specific lesion inside the retina, that's posterior uveitis, where you need a multidisciplinary approach with the help of rheumatologist, control the disease, and then go for surgery. Another important thing is that the last attack should be minimum 3 months of quiescent period without medication. So this is something which has to be there in your mind. Don't hurry up. So my approach is never hurry up, never hurry to do your cataract surgery. Just explain to the patient that you have this problem, you have to be properly treated before we go for surgery. What I do in my practice is that I give posterior subtenon Stricot at least 2 to 3 at 6 weekly interval and then go for cataract surgery. Also, I start the patient on systemic steroids, 1 milligram per kg body weight for 5 days prior to surgery and then taper. Now, intraoperatively, my main aim is that I have to minimize trauma to the eye because I don't want that my messy surgery should increase the risk of inflammation. So in the type of IOL, I would say a hydrophobic IOL, no fancy stuff, because I do not want even a small decrease in contrast for these compromised eyes. So friends, only monofocal IOLs, hydrophobic IOLs. Now I'm going to show you a video. This is a patient of cataract, uveitic cataract. I use this special thing called Discovisc, which has a combination of chondroitin sulfate and Helon, which helps in corneal protection as well as maintenance of AC. So I'm using these iris hooks. You have to be very careful with these iris hooks because you can tear the iris. And try and have a good stable AC without any leakage. And the way you plug this will help to prevent the leakage. Do a good capsulorhexis. Try to do a good capsulorhexis because we want the IOL inside the bag and not touching the iris. Otherwise, it will cause increased inflammation. So this is a hard cataract. We've used viscoat and we have divided it into a lot of pieces and then taking it out. So try and minimize any trauma in the phacosurgery. Once you've done this, do a good cortical removal so that again there is no inflammation. Do a good cleaning and do a removal of visco so that there is no secondary IOP increase because of leftover visco. Once this is done, we can remove it and we can see that the surgery goes fine, the eyes look good. Now there is another method. This is a video that my colleague has done, Dr. Deepa. So she tries and does the pupilloplasty with this method. So she is trying to make the pupil large by this, just a manual extension. This is one way of taking care of the pupil, doing a good rhexis. But here the important thing is that you have to keep your phaco probe in the center, because otherwise you might end up eating up the iris. So that is a tricky part, but this saves a little time. I tried it out in a UV. That was a glaucomatous eye, and with posterior synechia, I tried it out on a uveitic eye. So in this patient, when I tried to increase the pupillar size, I actually tore the iris to some extent, and I felt that probably in my hands the iris hooks works better. So to each his own, but the aim is that we have to reduce inflammation and we have to minimize the trauma. You can see here the iris is being torn because of probably the atrophic iris or what. Though the surgery went fine and we could do the surgery in a proper way, as you can see in this video. So my personal preference would be a little, towards iris hooks, because there you have a proper area to work on. So we could finally do. The good point about this patient was that the cataract was soft, and now we finished the surgery. So in the post-op considerations, you can have a mild flare-up, so don't leave any visco. Start the patient on systemic steroids, and also use homide for 2 to 4 weeks. Now another important thing is, if you hurry up and you are not control the inflammation, sometimes the iris bombay formation is there post-cataract surgery. Now that is a very, very tricky situation. You want to do a YAG PI. The moment you do a YAG PI, the inflammation increases. So you have to take care of it. So this you can manage by controlling inflammation and doing YAG. So never be overconfident. Surgery may be easy, but results can be disastrous and dangerous and very, very tricky. So do it with a proper approach after cooling the eye. Thank you.
Beautiful presentation, Ashish. As you said, like you want to make the eye cool before operating. If the eye has been a cool like for the last 2-3 years, now you are planning to do cataract surgery. So in such cases, what message do you want to give pre-operative any steroids in form of topical steroid, oral steroid, or giving posterior injection trigod? Like what will be your management?
Sir, at times when a patient comes with this, we are in a hurry to do the surgery rather than the patient is in a hurry to do the cataract surgery, to get the cataract surgery done. So my aim is that, though you are right, there has not been a redness in the eye, but there is always a chronic smoldering inflammation in these patients. So what I personally do is that I give a tricot, wait for 3 to 4 weeks, and after 4 weeks, then before the surgery, I start on systemic steroids. I am more aggressive towards reducing the inflammation, whether I am seeing it or not. That is what I have seen, and that way, I am more confident that I have done my complete job.
Right.
So,
very nice presentation, Dr. Ashish. But would you like to highlight what do you do in uveitis in children? Like there's a JRA with uveitis. How would you manage that case?
Ma'am, as against, we have to treat the JRA first properly, and then only go in for cataract. Cataract is the last option that I would like to go.
So how long would you give steroids post-operatively?
Post-operatively, ma'am, what I do is that during the surgery only I give a tricot after the surgery, and around 1.5 months.
So 6
slow
weeks,
taper.
yeah. Thank you so much.
So just one question, sir. So patient is having a vitritis and it's not going. So what to do in those cases?
So that is, you have to treat it. It has to go.
It's not going. I'm seeing it, the patient from past 6 or 7 months, but it's not resolving. So what to do? But cataract is definitely progressing. It's a 35-year-old female. She don't.
No, you start on a good systemic steroid. You give a posterior subtenance. You also start on a, some methotrexate or something like that, immunosuppressive. Try and reduce it. Otherwise, it will be a problem. Because once the inflammation increases after surgery and you start having iris bombay formation, then it will be a problem. It is very difficult to handle.
In the anterior segment.
Whatever, it is vitritis or uveitis, it is all a spillover. So you can't do either. Probably your diagnosis, you have to recheck whether it is actually vitritis or is it a resolving vitreous hemorrhage or what exactly is going on.
Intermediate uveitis.
Intermediate uveitis. So I would not recommend a surgery unless you are confident that the inflammation is under control. Or even if you want to do it, then take a 2-3 months period, give one subtenance, another one after a month or so, then another one, and then probably try out.
I think Ashish here rightly said, like inflammation has to be controlled. Sometimes like the smoldering inflammation is there. Sometimes you have to go ahead with vitrectomy also and put silicone oil in such eyes also if the eye is becoming.
Vitrectomy is an option. That is right.
And you have to put silicone oil. You have to give it time till that eye become quiet with help of oral steroid, immunosuppression. And when the eye becomes, then you can afford to take that silicone oil out. Because I've operated 2-3 cases like that in the last 20 years, not many, where smoldering inflammation was there, vision was going down, total cataract, total vitritis. So cataract and vitreous.
If you are going for vitrectomy, then you can remove the cataract at the same setting. That once we are doing a surgery, we are doing a surgery. If we
But I think then you can put injection Ozurdex also in such eyes.
Sure.
I think excellent presentation, and it's a very big spectrum of cases when we say uveitis cataract. So we can have a two set of situations. One is a very well worked up uveitis patient where you have ruled out all systemic problems, and it's a classical pars planitis case, idiopathic with cataract. I think there we are addressing, we try to clear the visual media. And if you have done maximum, given maximum immunosuppression in forms of oral steroids and other immunosuppressants for let's say 6 to 8 weeks, and still what you see is you feel like there is a vitritis, but it actually is a opacified vitreous. So they are all vitreous opacities which get created by long-standing uveitis. So that is one very well established indication for doing a vitrectomy. So those are the ideal cases for doing a combined surgery. But like Dr. Ashish rightly said, we never operate a hot eye. And another thing I would say that if your vitritis is not changing much after giving good amount of immunosuppression, rule out masquerade. Especially lymphoma is a big, very notorious thing, and sometimes you can miss all those things, so maybe you can revise your diagnosis of idiopathic pars planitis.
That is what you have to revisit our diagnosis.
And one more simple thing I'll add is when you are operating these complicated cataracts, there is a effacement membrane over a pupil. So you can easily peel it, and we have a luxury of having ILM forceps. That is very handy, 25 gauge ILM forceps. If you peel it, many times pupil opens up and it bleeds little bit, but that bleeding settles down very quickly. So, and then you can add on what Dr. Ashish has shown.
With the membranes in the pupil, I think we should do UBM also for seeing if there's any membrane over this ciliary processes and all. We have to treat accordingly. Yes, it can go in.
And one important thing is, if you see an iris Bombay, don't jump to do a YAC PI. Just see the pressure. If the pressure is towards the lower side or normal, then it means that because of this iris Bombay only this is the pressure. So if we do a YAC PI in a patient with iris Bombay and normal, you will have a phthisis. So you have to be very careful about that.
The thing is that before doing a mechanical stretching of the iris, I think proper cervicalis has to be done.
Yes.
Correct.
And one small point was the moment you start seeing iris Bombay forming in these complicated cataracts, probably that is a one clear-cut indication for surgery. Even when sometimes central lens is clear and patient is reading 612, and when inflammation settles down, we might improve to 6.9. But if you start iris Bombay coming up, best thing that you should prime that patient that you sooner or later now you need a cataract surgery. I agree, YAC PI doesn't work well. It occludes.
No, what I mean to say is that normal pressure and these don't do a PI because you will end up in a phthisis. Thank you.
Thank you, Dr. Ashish, for your excellent presentation and interactive session. Now we have second presentation by Dr. Abhishek, cataract surgery in pre-existing CRVO.
Dr. Abhishek Desai is working at Jalna and a proficient vitreoretina surgeon there.
Thank you everyone. Thank you for the kind introduction. I would like to thank Team Scientific Committee and all the panelists for giving me this opportunity. Today I'll be speaking on approaching a case of cataract with pre-existing CRVO. As we all know, CRVO arises due to thrombosis at the lamina cribrosa, and common risk factors include diabetes, hypertension, hypercoagulable states, and old age. Patient presents with acute decline in central vision, which is mainly due to macular edema and ischemia. Broadly, it is categorized into less severe non-ischemic variant and more severe ischemic variant because it is associated with anterior segment neovascularization and risk of neovascular glaucoma. Based on the recommendations of many landmark clinical trials, it has been advised that anti-VEGF monotherapy is considered as a first choice for these cases for macular edemas associated with CRVO over the corticosteroids due to associated other risk factors. And dense PRP is indicated in presence of neovascularization, mainly neovascularization iris. Now, approaching such cases of cataract with pre-existing CRVO, we should be thorough with our history-taking, ocular examination, appropriate retinal imaging whenever necessary, and keeping the primary care physician and retina colleague in the loop throughout the course is very crucial. Now, as we all know, apart from regular history, we should specifically ask for history related to the past episode of any thromboembolic events or any other positive systemic comorbidities. And in ocular part, we should ask whether they have received any injections, what are the number of injections and what kind of injections they have received. Is there any history of retinal photocoagulation, or what was the documented vision earlier? This is very important. And coming to the examination part, apart from our regular examination, we should specifically look for presence of RAPD, and in undilated pupil examination, we should look for neovascularization iris, neovascularization angles in association with the gradation of cataract and pupillary dilatation. In posterior segment, we should look for is there any active macular edema, ischemia, or neovascularization elsewhere present or not. Now, we all know the acute CRVO is easy to diagnose, but if patient doesn't give any history of, or if he is unaware of any CRVO episode in the past, how do we diagnose? So what are the signs or features that suggest or indicates that this eye had a CRVO earlier? So presence of venular tortuosity, deep retinal hemorrhages, especially in the temporal periphery, presence of disc collaterals, and presence or absence or signs of resolved CME, all these points towards the case of old CRVO. Now, if cataract is not so dense and view is permissible, then one should go for this specific test, or rather it should be mandatory, like fundus photography. It helps to document the progression of the disease. OCT is an excellent, OCTA is an excellent non-invasive tool which gives us an idea whether there is active macular edema or macular ischemia present at this moment, and it also helps to monitor the treatment response successively. FFA gives us idea about whether how much is the capillary non-perfusion, and it also helps to distinguish between the collaterals and the neovascularization elsewhere. And if cataract is very dense and view is not permissible, the B-scan or ultrasound is an excellent diagnostic tool which gives us idea about anatomical status of the posterior segment or retina to plan the cataract surgery. So with this history examination and diagnostic imaging, we will have a fair idea about the outcome of cataract surgery in these cases. That will help us the better counseling to have the realistic expectations of the patient. And that would also help to prevent unnecessary medico-legal implications and misunderstandings post-operatively. In such cases, it is better to wait for macular edema to resolve completely and to remain so without treatment for at least 2 to 3 months before planning the cataract surgery. Also, it is of paramount importance to have uneventful cataract surgery, especially to avoid PCR, as this would increase the VEGF load in the anterior segment and hastens the process of anterior segment neovascularization. As with any other posterior segment pathologies, monofocal hydrophobic IOLs are preferred over multifocals and silicone IOLs because that may hinder the posterior segment visualization later if any posterior segment intervention is required. A close follow-up and treatment when indicated for at least 2 years is very crucial to reduce the risk of losing visual acuity in such cases. These cases are more prone for pseudophakic CME post-operatively, so it is better to start them earlier on topical NSAIDs for the resolution of CME and for its treatment over no treatment. Now, having seen the basic knowledge how to go about this case, let's see a few case scenarios in short. Suppose there is a case of acute CRVO with CME and cataract. What should we do? We should continue anti-VEGF, wait for the macular edema to resolve, and then plan the cataract surgery after proper discussion with the patient and patient's primary care physician. Now, suppose there is a cataract and old CRVO, we do imaging, there is no edema, then you can plan cataract surgery immediately. But to look post-operatively specifically for the anterior segment neovascularization to prevent risk of neovascular glaucoma or to diagnose it earlier. Now, if there is a dense cataract, no fundus view, but there is a documented record of old CRVO, after proper anterior segment evaluation and posterior segment evaluation, if posterior segment is normal over B-scan, plan cataract surgery, have a thorough examination and imaging later post-operatively, or have a retina colleague's opinion. Now, somehow we face similar such cases. Sometimes the edema doesn't go no matter what you do. Then what to do in such cases? There is a cataract and non-resolving CME. For example, in this case, this patient presented with acute CRVO with edema. Initially, it responded well with the anti-VEGF. But after a few days, again the edema rebound, there was a rebound macular edema, and which was not going easily. In such cases, continue the anti-VEGF and follow treat and extend regime over the PRN regime, and you can plan cataract surgery if cataract is very significant under anti-VEGF cover. So the predictors of good visual outcome in such cases is younger age at presentation, good baseline visual acuity, and intact subfoveal ellipsoid zone. All these points towards the good visual outcome. So while approaching these cases, our goals should be to improve and stabilize the visual function and vision related quality of life, to detect timely and treat neovascular complications and macular edema, and to control the modifiable risk factors through direct communication and coordination with the patient's primary care physician to prevent similar risk in the other part of body and other eye. Thank you. Thank you for patient hearing. Thank you.
Nice presentation. One point is like you talked about giving anti-VEGF therapy to reduce the macular edema and doing cataract surgery. What about giving Ozurdex injection in such patients vis-a-vis anti-VEGF injection in such cases?
Sir, steroids, no matter, it does help in these cases. That also provide level 1 evidence. But anti-VEGFs are preferred over the steroids because the risk of glaucoma is less. And also, as per the documented evidence, VEGF is preferred over the steroids. If VEGF patient is not responding, as per American guidelines, we should inject 6 continuous injections before switching to any other injection or Ozurdex to have a steroid rescue before switching to other anti-VEGF. But in our setup, in our country, it is difficult to convince for 6 injections if it is not responding. So based on patient to patient, we need to decide whether what is best possible solution for that particular case. But yes, Ozurdex can also be
It's
given.
a good option.
Yeah.
Giving long-term
Yes.
treatment.
But after 3 months, once its effect wanes off, there is a bad rebound edema is what I have seen.
What
So
is your take on Dipender and Ashish?
See, steroids are definitely a good alternative in operative
Yes.
period
Yes.
for all these macular edema cases. But you rightly pointed out in Safodex study, the risk of steroid-induced ocular hypertension was highest in vascular occlusion group,
Yes, sir.
almost 35%.
Yes, sir.
Compared to DME, it was hardly 20%,
Yes, sir.
and uveitis was in between.
Yes. Sir.
So yes, I would also be little hesitant to give DEXA to all CRVO patients before cataract.
Yes. Sir.
But if they are with you for some time, you can do a steroid challenge test. You can put them on steroid drops and maybe give couple of anti-VEGF injections. And during that period, you judge their steroid responsiveness. And when you are planning cataract, then if they are non-responder, then you can still use DEXA implant.
Yes.
But you rightly said, overall, I think this whole topic needs mainly management of CRVO like we
Yes,
do, and
sir.
it's not a good disease for anybody to
Yes,
have. We
yes,
all know
sir.
that.
Yeah.
So, but we should not also be depriving them of cataract,
Yeah.
because many of them do get stabilized either because of collaterals, and you take care of ischemia.
Yes,
and
sir.
depending on your threshold to bring PRP,
Yes, sir.
do a proper laser, and then we should operate them. But of
Yeah.
course, just like we do for PDR cases.
Yeah, in that case, that's why the pre-op counseling is very important to have realistic
Only
expectations.
thing which I am little much more careful in these cases is not to miss an NVI,
Yeah, that is
because
true.
intraoperative
Yes.
and then post-operative
Yeah.
problems can be
Yeah.
even if you have to do a intense PRP, if you see
Hmm.
even if you have slightest doubt of NVI, do an aggressive PRP
Yes.
before cataract,
Yeah.
because they can suddenly change gears.
Yeah, but sometimes if cataract is dense, view is not possible, you can plan PRP immediate post-operative period also. Yes.
Correct.
Yeah.
Ashish and Kenshuk, anything they want to
Thank you.
point out?
Sir, I will be taking some points in the next
Okay.
Okay. Thank you. Thank you, everyone.
Say that if the approach is quite good, you get 2 or 3 anti-VEGFs and then probably aim for either an orthodox or a cataract surgery.
But sir, in perioperative period, giving steroid implant is also increasing the risk of infection post-operative period. Because I have had one end of when I planned DME and cataract surgery plus Ozurdex in the same sitting in table. So that from that episode, I'm little hesitant to inject steroid implant
Normally
during
we give
surgery.
2 weeks
So
prior
Ozurdex,
to-
when do you give Ozurdex? Seeing the visual acuity or the thickness on OCT?
Uh, Basically, I would never prefer Ozurdex over anti-VEGF. I'll always give anti-VEGF try over Ozurdex. Unless and until if it is not responding, then only I will think of giving Ozurdex. Only if that PC is intact, patient is pseudophakic and no history of glaucoma and cupping in the disc. PC intact should be there. In YAC patient also, I would not prefer Ozurdex.
Right. Thank you, Abhishek.
Yeah,
Now
thank you.
we have our next speaker, Dr. Kenshuk. He will be speaking on cataract management in pre-existing BRVO.
Last hour. A very good afternoon to the esteemed speakers who have come, and Dr. Desai. I think he had a very great talk on the pre-operative evaluation and what are the things one has to look for. So I think pre-operative checkup is the must, and looking carefully and examination history and post-operative follow-up with the physicians and sending back for hypertension control and other factors is very, very important. So I am going to take about the questions that had come about the anti-VEGFs and the Ozurdex and the Tricot. So I will be concentrating more on the BRVO aspect. So prevention is better than cure. So sir was saying that one of the patients had a end of when he had a combined surgery. So there's something called the PIE, which is the post-injection endophthalmitis. So once you are doing 2 surgeries, so you're actually having a double trouble. So what I do is we actually put Paracaine outside also and start antibiotics 2 days prior, as well as do a cleaning outside the OT area, and also we flush and with betadine during the combined procedures. So prevention is always better than moving forward for any treatment. So, which techniques to opt for in this cataract surgery? So, we are living in the modern age of phaco. So, phaco is faster and better than the conventional surgeries. They cause less inflammation and less edema. So, we would prefer, and especially if patient can afford flax, why not give him that option? So, that is also an option for the patient for increase, but the cost is more, and the other factors the insurance doesn't cater for. Most of the patients nowadays in cities are mostly insurance patients, so they want everything cashless. So intraocular lens options, my option would be always unifocal, but various studies have found that toric IOLs also give good post-op results. So toric monofocals can be also a good option. So comparing different intraocular lenses, like I said, toric IOLs in one of the studies was found to be better if somebody had a slender of minus 1.25 cil or more. And coming to the use of anti-VEGF injections, definitely it should be, like sir was saying, it's a first priority. And some of the the new age, the in the new age, we are giving injections for almost every cases. So, I don't stick to that. I don't prefer to give anti-VEGFs in new vascularizations. My first take is always laser. If any patient is having NVI or, and like sir was mentioning that, go far up to the periphery in CRVO, BRVO patient, because it is just not the posterior pole. It is far up to the periphery where this ischemia is present. So we are doing laser to prevent the ischemia and its further complications. So the earlier studies, in 1984, it was shown that, grid laser and these things are, still used in specific cases, depending on non-compliance and other things. But still, photocoagulation should be done in cases where there is development of neovascularization. So I would prefer to, preoperatively do a FFA. And my take is that, FFA is still very, very good tool. It is just that it takes just extra 10 minutes, but that 10 minutes save your life and, give you a much better picture of actually what is happening in the retina. So if you find a NV, so either if the visualization is good, you can go ahead with the laser, or just wait for 2 weeks and after 2 weeks of cataract surgery, do that laser. So ranibizumab also stood the test of time, and now in the Indian scenario, we're having so many new companies that are coming every day. So like the biosimilars and all. So with the biosimilars, prefer to take a special consent of the biosimilars, and I prefer to use what are the local Razumab, because that cuts down the cost. Insurance also gives it. So and aflibercept, through various studies of Copernicus, Galileo, and Vibrant studies have shown that aflibercept is also good. So ranibizumab is non-inferior to aflibercept. So you can give that option to the patients. And see, delaying treatment for the anti-VEGF, because it is an additional cost, so patient might not want to take it right that time, but tell him that if you don't go in for an anti-VEGF, that no treatment for the BRVO will cause an inferior visual acuity. So it is in his thing that we have to give an injection. So it is better to start with the anti-VEGF with the cataract rather than to wait. So now off-label compounded therapies are also available, like Zaltrap, Avastin. So patients who cannot actually afford biosimilars, also only those patients I give this option. So treatment schedules, treat and extend monthly evaluation. That is the way I go for. And long-term anti-VEGF outcomes, like sir was saying, that you follow up for 2 years. But most of the studies have shown that even after 4 years there is a chance of recurrence. So the main thing is counseling to the patients and counsel again, and so that they don't misunderstand you. So it is very important to counsel the patients that about the visual acuity, because the expectation these days is too much, because they always compare themselves to their neighbors, and he got a better vision, he was operated by you, but he got a better vision. So, sir was also mentioning the Ozurdex, the contraindications if the patient is already having glaucoma. So, have a look at the disc properly, that it is not you don't have a hint of glaucoma there. Avoid in those cases disrupted posterior capsule, phakic eyes, and secondary IOLs. So that has to be taken care. And seeing for the Ozurdex, so like in CRVOs, I find Ozurdex to be working very well for the patients, and a repeat 3 monthly can be given. So my take is that Ozurdex should be repeated 3 to 4 months, but that should be counseled to the patient. And SCORE 2 study, like he was saying, that anti-VEGFs and after that give Ozurdex, because those studies which had a switchover after 6 months, in those studies already aflibercept was given. So the sample size of the patients were very less who were actually switched over to Ozurdex. So I have 2 case studies here. So one of the patients presented with sudden painless decrease in vision to 660, and he had STRVO and CME, and patient wanted a EDOF because one of his neighbors wanted it. And post-operatively after a month, this was the top picture is the pre-injection and cataract surgery, and this was after 1 month. So patient is doing well, and calling him at 1 month follow-up. And the other patient actually had come from abroad. He had a cataract and a CME, seen piece STBRVO, and the vision was counting finger 5 meters. Since he didn't have adequate follow-up, at her country. So we decided to inject Ozurdex after trial with Vigadexa for 1 week. So since patients have less time and they want it quickly sometimes, so sometimes we give a 1 week, but ideally it should be a 2-week trial of a steroid test should be done. So we injected Dexa before the cataract surgery. We had told the patient that you should get it 2 weeks prior, but they wanted it at the same sitting. So basically the future directions in this field is that you look into the latest research, the statistics which are there, and take a call according to that. So the key uptake is stay up to date and give the best to the patient, which we all are doing, and counsel. That is the main thing, and document everything. Document that you will require multiple injections. You require to come on follow-up, write it down on the prescription and give it to the patient. Thank you so much.
Thank you,
Thank you, sir.
Doctor. So anything, Dr. Ashish, anything you want to point out?
Presentation is rightly pointed out that you need to take care of the BRCO and then go ahead
And
Yeah, thank you so much.
proper documentation and counseling is must actually. So we have our next speaker, Dr. Manisha Nada, who is Professor of Ophthalmology in Medical College Rohtak, and she will be talking on managing coexisting cataract and diabetic macular edema.
So it's a double trouble when we have cataract surgery along with diabetic retinopathy. So we cannot escape. We need to know the nuances, and we have to manage effectively with the aim of good visual outcome any case of cataract surgery with diabetic retinopathy. Trouble is actually manifold. Trouble is specific to the cataract surgery. It could be rigid pupil along with autonomic neuropathies or glycogen deposition. There can be increased reaction to surgery. Inflammations are always more with diabetic retinopathy. Neovascularization of iris could be there. Zonular instability is definitely there in advanced cases. And the type of cataract also. In my experience, I think it's thicker, harder cataracts along with diabetic retinopathy. So troubles secondary to systemic effects are there. There could be glaucoma, vulnerability for infection, and additional comorbidities. And the master trouble is acceleration of diabetic retinopathy. So why it's important to know? Globally, we know that cataract is the leading cause of blindness, and a lot of people are getting affected, and it's going to be a tsunami after many years. From now, about a decade or 2 decades, I can say. Overall, it is estimated that up to 20% of all cataract surgeries, they are performed in diabetic patients overall. The first step is we should explain the pathology and the visual prognosis to the patient. Needs a lifelong follow-up, and the patient should be ready for repeated interventions, and detailed consent is always required. So it's an opportunity for us to counsel about diabetes to the patient when he comes with cataract to us. So what are the pre-op considerations? Systemic, we need to have a good glycemic control, assess for any systemic effects, nephropathies, cardiomyopathies, and so on and so forth. And ocular, we have to see for myomitis, blepharitis, recurrent erosions if they are there. We need to control them first. And keratometry also varies. So when the eye is stable and the cornea is fine, we should do keratometry. Glaucoma can be there, cataract surgery or combined surgery can be planned. We need to know the status of the pupil, cornea for neovascularization of iris. Need to grade the cataract. Locks grading can be done, and gonioscopy for high-risk PDR if it is there. Fundus photography, autofluorescence, fluorescent angiography has to be carried out. OCT and OCTA, and also ultrasound is important. So diabetics have much higher inflammatory mediators, we all know, interleukin 2, 10, 12, interferons, tumor necrosis factor, VEGFs. So pre-op NSAIDs should be given. 1 week pre-op napafenib, bromfenib or ketorolac needs to be given and should be continued for 4 to 8 weeks post-operatively. And if the patient is a glaucoma patient, we have to stop the prostaglandin analogs 2 weeks prior to surgery. And what are the intraoperative considerations? Pupil management. Preoperatively, good pre-op preparation has to be made for the patient, and YAG laser mydriasis needs to be done. Intraoperatively, aniline, avoid iris touch, chafing, pupil expanders can be used, as it was shown by Dr. Ashish. So we can do pupillary stretching, multiple sphincterotomies can be done, retractors can be used, and other devices which can expand the pupil should be used. So phacoemulsification should be the choice. And what are the tips we should take care while there is a diabetic retinopathy in cases of cataract? We need to do careful biometry, especially in silicon-filled eyes. Rexis has to be, minimum should be 5.5 millimeters. There should not be any capsular phimosis, anterior or posterior capsular opacifications. Good viscoelastics for endothelial protection should be used. Gentle hydrodissection is required because we know that the zonules are always weak. Complete cortical cleaning is must. No PCO is required, should not be there. Thorough capsular polishing, and in the bag IOL positioning has to be made, and suturing of the main wound if required, and we need to meticulously remove the visco once the surgery is over and nucleus is out, clean the visco properly. What are the choice of IOLs we can make? We have to consider large diameter IOLs, single piece PMMAs, surface modified heparin coated or fluorinated lenses, and we should avoid silicone foldable IOLs. Multifocal IOLs should be avoided. Contrast sensitivity is reduced in such cases. AC IOLs and iris fixated IOLs also should be removed. It should be avoided. Worsening of the pre-existing diabetic retinopathy, and there is an increased rate of retinopathy progression and worsening visual acuity in eyes undergoing cataract surgery compared to unoperated fellow eyes in people with diabetes. We all know ETDR says that, and Deniston et al. They said that significant post-operative progression of center involving diabetic macular edema occurs after cataract surgery. So perioperative intravitreal steroids and anti-VEGF agents are a good option. So worsening of diabetic macular edema was seen in a patient. There was a 56-year-old female with diabetes for last 15 years and with poor control. The vision was 6/18 and was under good diabetes mellitus control. Anti-VEGFs were given. The patient was lost to follow-up for 1 year. The best corrected visual acuity as the patient comes is 636 on a follow-up, pseudo-faking, and now the patient is unsatisfactory and unhappy because of the edema. So this was the picture. You can see that the edema, it increased with time, and later on anti-VEGFs were tried and this all subsided, and we had a normal macula later on. So PDR, proliferative diabetic retinopathy, patients with pre-existing untreated PDRs, they are likely to progress and develop vitreous hemorrhage and other retinal complications. PRP is recommended preoperatively in PDRs. When the cataract is dense and prevents preoperative PRP, two options are there. Indirect PRP immediately following the cataract procedure should be carried out. Plan and perform within a week after cataract surgery. Cases with dense vitreous hemorrhage or for eyes with posterior polar tractional detachment, combined surgery with vitrectomy and endolaser photocoagulation should be carried out. So cataract surgery and intravitreal injection of intravitreal steroids can be planned simultaneously with cataract surgery. Diabetic macular edema with ERMs or tractional component, particularly if the patient has not been treated previously, plan the intravitreal steroids. It can be done during cataract surgery also. We can do ILM peeling in eyes with persistent diabetic macular edema. It's beneficial. Post-op care, suppress the inflammation. Glaucoma has to be controlled if it's there. Avoid early YAG cap. Keep the pupil mobile. Evaluate and treat diabetic retinopathy early before the PCO develops. Refer before there is acceleration of diabetic retinopathy. VR surgery can be done after 1 to 2 weeks. And laser PRP can be started on day 1. So the conclusion is, depending on the degree of diabetic retinopathy, individuals with visual significant cataract, they present special obstacles during surgery and subsequent rehabilitation. With appropriate treatment, such patients can achieve excellent vision. Anticipate the trouble and do a meticulous pre-op workup. Perform early cataract surgery and treat DR. Be on a lookout for any worsening of DR and manage on standard lines. Thank you.
very comprehensive and excellent presentation, ma'am. And I think this is probably out of all the situations we discussed in this session, this is probably most commonly seen in our practices. And I would see it in like two set of scenarios. One is a DR patient being treated regularly and now he or she develops a cataract. And second scenario is patient who is seeking an opinion for cataract is found to have both a treatable center involving DME and a treatable cataract.
Yes.
So approach I think to both of them will be little different. For a patient who knows everything about DR and getting treated for DME regularly, he probably needs to be counseled about the visual gains he can expect, and also that need to continue DME treatment for long term. And probably most of us would operate them at the time when macula is dry, because he's already on injections, so
That's
he understands
important,
the
yeah.
concept. But this patient, which is a treatment naive patient, and he came for cataract and now he is found to have DME, we need to spend much more time on him, and we have to, main issue what we face in our practice is to tell them and guide them which is the core issue. Sometimes they are so much focused on IULs and cataracts, they are ignoring the fact that they also have a sight threatening disease. So I think that's a very important part of our counseling, and rest of the things you very well I think explained how do we address.
There's one third scenario wherein the patient comes with decreasing vision because of slight diabetes and when you see, you feel that you are not able to do laser because the cataract is more dense. So what I do in these patients is that I ask the patient, I just give a sugar injection to a cataract surgery that gives me a month's time so wherein I see my missing. The aim is that before that I should not be late in therapy. We should not develop a neovascular vision or something like that. So what I do is I do an injection for cataract surgery. Then after a month, we do the laser once the
Then we need to do ultrasound in all the advanced cases of cataract, yes. Yeah. Yes, yeah. Thank you so much. And I would like to thank Dr. Partha for giving us this opportunity. It was a very well invited session, and all the speakers, I thank sir on behalf of everyone out here. Thank you so much. Yeah.
Thank you, ma'am. And now I think we'll invite our next speaker. We have a little change in lineup of talks. Dr. Arvind, he has to attend another session going on at same time. So over to you, Dr. Arvind. Will not.
Good morning, everyone, and thank you, AIOS, and especially Professor Manisha Nada for giving me this opportunity to be a part of this wonderful session. So my talk is on triple trouble, premium IOL selection in a patient of mild non-proliferative type of diabetic retinopathy. So this was a 45-year-old diabetic patient, well-controlled blood sugar levels with glycoside well controlled, intermittent cataract, wants no spectacles after surgery, and he is a 10-meter air pistol shooter and loves driving. He has a mild NPDR with very healthy macula and normal range IOL power with no astigmatism. So which IOL to choose? Okay. So for the intermittent type of cataract, we have developed this technique of sieving needle microcapsulotomy. So this is how it is done. A small bent needle is used. So it is giving a microcapsulorhexis, and this liquefied cortex comes out as a volcanic eruption. Now you can see it's a round regular margin, because cystitome, it has irregular margin and gives a linear cut. And then we are able to make the intended 5 to 5.5 millimeter of rhexis quite easily. So which IOL premium IOL to choose that corrects all types of vision, no dysphotopsia, no glare or halos, because patient loves driving and he is a shooter. So the 10-meter air pistol, they have very small bullets. So the patient needs very good intermediate as well as near vision also. And so it needs to be pupillary independent also. So this is the answer to all the problems. That is Autofocus Pro. It looks almost like monofocal, but it works like multifocal. So it is an aspheric polyfocal progressive lens without any diffractive rings, static and fixed in the bag, and there is no mechanical pseudo accommodation, yet it functions like a autofocus lens as the name given. It is a progressive type of IOL as seen. And this is the size of the design of the this Autofocus Pro. So this is the design of the Autofocus Pro. So the L loop with zigzag outer edge and square edge prevents any PCO, and 360-degree Amon-Apple posterior square edge there, polyfocal progressive optic, and the size of this is 13.0 millimeter. With the optic size of 7.5 millimeter, so there are no chances of dysphotopsia.
This is the schematic diagram of autofocus progressive
Iska volume
polyfocal
band kar
optic,
dijiye, please.
which gives
So there is excellent DIN vision, distance intermediate near, by GRIN technology, that is gradient refractive index, and there is no loss of light energy. So these are the different zones for distance, intermediate and near. And there is no light energy loss because there is no destructive interference or diffraction, and angle kappa or angle alpha are of no significance value. MTF is very good. The highest MTF is better. The ideal MTF is 100%, but it is not possible to achieve. And most of the monofocal IOL, they have 70 to 80% of MTF, and most ring bifocal and trifocal have 30 to 40. So the image is misty, blurry, waxy, and contrast is low. Whereas Autofocus Pro, although being a progressive multifocal, has multifocal value around 70%. So thus IQ at retina and contrast are as good as a monofocal IOL. And there is no optical noise, so there is almost no neuroadaptation is required. And one eye Autofocus Pro and other eye ring bifocal, so this was the difference in the vision quality. It was waxy, misty vision, whereas it was free, crisp, sharp vision in case of Autofocus Pro. And out of more than 5,000 implanted, not a single patient complained of negative dysphotopsia, because dysphotopsia is because of this space, right? And in diabetes, of course, with healthy macula, we can implant this lens without hesitation because there is no double or triple diffraction of green laser spot. If at all, they need PRP in future, and larger size of IOL optic body is also a good advantage for retina surgeons. And this is a difference in the night vision with the trifocal, and with the other side is the Autofocus Pro. So it can be implanted in night drivers also. Anyone who is fit for progressive spectacles is fit for this IOL. And my acknowledgement to the inventor of this wonderful IOL, Dr. Jagdeep M. Kakadia and Dr. Ramesh Shah. Thank you so very much.
Thank you, Dr. Arvind. I think this lens is specifically not made only for diabetes. It can be used for anybody.
Yeah, definitely.
And this is
very cost effective.
Commercially available?
Yeah, it is commercially available.
Okay.
Yeah.
And how many cases you have done with?
I have done 23 cases.
Okay.
Yeah.
And
Contrast sensitivity with this.
Yeah, it's very good. It's very good. Yeah, clinical trial is going on, but we have done, the sample size is 153. We have done only 20 cases, so it's too early to be conclusive. So just wait for a few months, then we will share the results.
I think excellent. But just a question, I think not less scientific and then less ophthalmic. How could you capture those two set of photographs through IULs? Or was they are just representative photographs, images?
Yeah. As the patient says.
Okay, it's based on their descriptions.
Yeah.
Okay.
Based on this.
No, I thought maybe we have a technology to do that.
No.
If we can put it over SLR or something, and to see actual difference.
It's a very good suggestion, and we will think about it. If it can be done, it can be attached to the mobile camera and can be taken. So we will definitely go for
This
it.
has been done actually. This has been reported.
Okay.
Putting IOL on a mobile phone's camera and recording pictures through that. But that much.
MTF functional documents or just a picture image?
No, that was, I think they did to capture retinal images and all those things, but they were not evaluating IOL performance through this technique. Yeah. But I think real life, experience through that different IOLs, that would be interesting. That keep telling them, these premium IOL people, that you should do more real life studies. Let them walk. Yeah.
I had a real life experience with a Brazilian and there was a doctor I had operated in pediatrician. He was 6:30 we went out and I told him to look at the report.
Yeah.
But at low light conditions, I realized that because of everything, he's not able to see. While in good lighting conditions, everything was good. So what when they say in multifocal that it is 98% contrast, that 2% is there in the low light conditions. So they do not appreciate the difference. That's not a thing that comes. But as you said, it's a good food for thought.
Yeah.
Please evaluate and
Yeah, we are doing a clinical trial, first such clinical trial. So it's too early to say or comment. So I won't.
Even Vivity also gives halos and glare while night driving to so many patients.
So there are diffractive zones, no, sir? But
Just another EDOF lens.
Yeah.
The company in fact doesn't promote it too much. They say the first option of their concept is this particular company that you go for their trifocal as they call it.
Yeah.
And because all this like competition is coming up with this things are promoting, they also want to have it. So none of these are perfect. So counseling is the most important thing. The whole trick is in counseling the patient and chat.
So can we use these lenses in children also?
yeah. Why not? If the astigmatism is less than 1, we can go for this level. Because
Some
they are not
ectopia
available in
lenses and all,
toric variant.
Patients come now where there's a weakness of the news, accommodation is not there.
No, it's not. Even we have put in a traumatic mydriasis patient and very good distant, intermediate and near vision.
I think, but the
So
main
it's-
selling point would be to test them on patients with macular pathologies, who are prone to have much more impact on contrast and all.
Yes, we applied for that, but ICMR rejected that already this is unhealthy, so they won't permit us. ICMR rejected our proposal. We tried for that. So maybe later on we will again try and submit our proposal.
In general, a word of caution, not just any multifocal, trifocal, any lens which is serving more than one focality. One has to have a word, there should be a note of caution and the patient should be counseled.
Yeah, but it's more like a monofocal. There are no diffractive.
That's what they say about EDOF, that's what they say about enhanced.
Yeah.
Even all there also, because the light is, whenever you play around with optics, there would be a compromise. So what I tell my patients, these are all compromised lenses. That's the term I use. You are getting increased enhanced functionality, but at a certain compromise. So these are compromised lenses. Get it drilled into their head. Make them be responsible for their decision. Because then it's easier for them to live with it.
Yeah, counseling is very important. Yeah,
These are compromised lenses.
Absolutely. Same, we also
So say that and they take a conscious decision. I recently had a patient. He's very well educated, very smart person. And then this guy, he was considering various lens companies and finally comes to between Vivity and Panopticus. So I had to tell him about all the pros and cons. Turned out to be a good result, but of course,
but night issues
there's a little bit of dissatisfaction, but now he and his whole family knows that we talk went back and forth so much that the onus is on him. So what did he choose? He chose. I could choose, right?
he chose.
He chose.
He only knows what he chose.
I also ask you about talking, right? I can only guide you.
Yes.
The decision has to be yours. I'm never going to tell you.
That is the best thing to do, because if the patient is 100% ready and with all the cons and pros, then only these type of yeah.
And you know how they perform, you know how what adjustments you have to make your A constant, what city का क्या करना है, सब कुछ पता है.
Right, so
Patients are sensory system has to be a part of it.
Yeah.
It's a big variable.
I think
Absolutely.
in interest of time, we'll move on.
Thank you so very
But
much.
This is a very exciting discussion.
Yeah, we can have a
over coffee.
this session only.
Yeah. So now we'll invite Dr. Neeraj Sandhuja, who needs no introduction, and he's a He has a roaring practice at Gurgaon and prolific VR and cataract surgeon. He'll be speaking on neovascular AMD and cataract. Again, very frequently seen double trouble.
Thank you, Dr. Dipendra. Dr. Manisha. I'll be speaking on decision making in cataract surgery in cases AMD. So as far as this surgery is concerned in this AMD patient, it is very important to counsel. Whatever we talk about, whenever we talk about lenses, we talk about counseling. So counseling is very important in such patients because these patients are having center involving macular degeneration, and the visual results are not going to be very great. And though we have seen like vision mostly it improves whenever you operate such patients in form of improvement in contrast, improvement in total amount of the light which is going into the eye, and sometimes the visual results are very gratifying. And a recent study identified that the risk of fall in such patients decreased by 54%. In elderly age group, you can see the patients, they keep falling, injuring their bones and getting into fracture. So the risk of injury reduces a lot. So these patients should be given a trial of cataract surgery. It's very important. And this is quite debatable whether the cataract surgery causes AMD to progress. I've seen in my scenario 1 or 2 cases landing up into from dry to wet AMD out of thousands of patients. So I don't think that was just a chance finding. And even all the surgeries, they have been debatable. But we do tell our patients like the AMD may keep increasing, but it will not increase the risk of progression of your AMD. So the patient has to be told in a very justified manner. And screening for macular disease with optical coherence tomography has changed the way we look at things. We all know about that. We don't go by only clinical examination, but OCT is an important tool. And the thing is, this question comes to us like how long we should give these patients with intravitreal anti-VEGF therapy before giving cataract surgery. So in general, a lot of studies, they have shown if you have been treating these patients for the last 6 months, if you do surgery after that period of time, patient is also mentally prepared, and also anatomical outcome in terms of deterioration of vision is much less because the disease has stabilized in most of such cases. And predicting visual acuity outcomes, it is challenging, but the poor visual outcome is mostly seen in patients where there is a longer duration of AMD in intermediate AMD, and ellipsoid zone disruption is very important to see. If ellipsoid zone is disrupted in neovascular AMD patients, so such patients, they are not going to get good vision, and you have to prognosticate such patients. As far as the intraocular lenses are advised, monofocal lenses are the lenses which should be preferred in such cases. No going for heavy profile, multifocal, monofocal with extended range of vision. All these lenses or EDOF lenses, they don't help such patients because already the contrast is reduced, and these lenses, multifocal lenses, they give higher order aberrations, so better to avoid such lenses. Go for monofocal. Tell the patient you have to use glasses for reading, and for distance also you may need glasses, and also sometimes you have to give low vision aid. So putting a multifocal lens is going to be a big no in such patients because low vision aid will not going to help such much in such cases. Toric intraocular lenses should always be put because we should try to reduce the astigmatism to as nil as possible. And aspheric intraocular lenses should be choice in such patients. And there has been a lot of debate about blue blocking IOLs, but it did not statistically significantly decrease the likelihood of further progression of neovascular AMD. So any lenses which we use for ultraviolet blockage and blue blockage, they do as good as like any other lenses. And there has been a debate whether we should put special type of lenses like telescopic lenses or Galen type macular lenses, because these lenses are indicated in a certain subset of patients where the total size of the lesion is less than 1 disc diameter, because these lenses, they are going to focus the light away from the center of the fovea, but the degeneration, whether it is a form of scarred CNVM or whether it is a geographic atrophy, it should not be more than 1 1.5 mm. So only those things it can help. And also in such cases, the anterior chamber depth has to be really good, because these are little bulky lenses. You can see, look at the design of the lens, quite bulky lenses. So anterior chamber depth has to be good. You can't use in glaucoma patients such cases. So this is the macula lens. It is kind of telescope implant which helps in improving the vision. Intraoperative consideration, it does not make any difference whether you give anti-VEGF at the time of the surgery or you give 1 week prior. But mostly generally we give 1 or 2 weeks prior to surgery as a standard protocol. But even if you give in the same day, it does not change your visual outcome. And such patients who receive multiple injections of intravitreal drugs, they are more likely to develop sometimes some micropuncture into the posterior capsule and zonular dialysis also. So you have to be a little extra cautious while operating such patients, because you can land up with some challenges of posterior capsule rent in such cases. And also you should reduce any unnecessary light exposure once the cataract is out. Once the patient is aphakic, you should not keep waiting. The lens should be loaded and you should put it as early as possible. And as far as the flux is concerned, the post-operative course between this conventional therapy and femto laser has nothing to do. Any surgery with a good surgeon is good enough. And such patients who have received multiple injections, they are more likely to have some complications of endophthalmitis. Various studies have shown. So you have to be a little extra cautious by treating such patients, keeping a close watch in such eyes for any undue amount of inflammation. So the conclusion is, there are quality of life benefits in carrying out surgery in visually significant cataract in patients with all stages of AMD. So preoperatively, you have to do the OCT and avoid multifocal intraocular lenses, and plan your surgery after at least 6 months you have given these intravitreal injections. And during surgery, you have to take care of any inadvertent PC rent and reduce unnecessary light exposure. Thank you.
In near future. Excellent presentation, Dr. Neeraj, and I think you have covered almost all the points relevant to this situation, AMD patient undergoing cataract surgery. I think I'll just add that as far as this progression of AMD now issue is more or less quite settled in literature. Most reports now finding no progression. Even meta-analysis and all these studies.
Even real-world scenario, in our experience also, we have not seen any
I think the final conclusion is that it doesn't. Rather, if I see from different perspective is, after cataract advances too much, the sensitivity of your Amsler grid and other things to detect a small CNVM and metamorphopsia also goes down. And that is how we counsel our AMD patients, that even if you have a risk of converting to wet AMD, if you allow your cataract to progress to very advanced stage, you will not be able to judge it whether you are having metamorphopsia and other things. So it might be detrimental to delay cataract surgery in them for quite some for unnecessarily. Obviously, you will operate when there is a visually significant cataract.
And also, like the risk of fall means it reduced by 56%.
Other risk,
there's so many other things we are depriving them of. This,
only thing is to make them realize that your central scotoma. So what we do is, the moment they start developing cataract, you start telling them and start making them aware of their scotoma, that how much area you don't see. If they can start feeling it, they will accept the result of cataract surgery very gracefully, because they realize that scotoma is not going to disappear. And you rightly pointed out that intensive phase of CNVM management, when you deal with a treatment naive CNVM, is for 6 months. They are overburdened by too many visits, multiple monthly injections and OCTs. So probably we should delay the cataract surgery once this intensive phase is over, and you can do cataract in their maintenance phase when they are on PRN, coming every 3 months or 4 months for injections.
Correct. That breathing space has to be given to the patient.
Yeah, absolutely.
Otherwise, he will not stick to you. He will not stick to you also.
Because unlike DR, where you have to do laser, you want early cataract and early you want to treat the proliferative part, there is no urgency here.
But the counseling part is what as you rightly said, what I say if you have this ARND, you have that central control that is not going to go. But now what you are seeing is what we see in pollution that once we updated, you will see whether it is something like after after rain there becomes clear. So this side thing will be better, but these central control will be less. So you need to counsel the patient what he needs to expect from you. But just last one question. You were talking about those telescopic lenses. Have you seen any patients?
No, actually, care group, they manufacture. They came to me and told me the indications also. But I think we can use. Never had those guts to.
One of our alumni, he was my group mate only, Dr. Amol Kulkarni. He was part of the trial for IMT. He shifted to US after his MD. So his first-hand feedback was this: there were very high incidence of decentrations, PCOs, and overall visual performance of these lenses. That's why even in there also they didn't use it after the trial was over themselves.
Okay, thank you very much.
Very nice presentation. And I would like to add that in early cases of AMD or the dry AMDs, you can go for premium IOLs. And also important that multifocals, they should be avoided in cases where you want to see the retina. You have to do indirect ophthalmoscopy and various other tests. So avoid. So in it, yeah. So 2-3 things are important, है ना? Early and dry AMDs. Go for any IOLs the patient wants. Whatever patient wants in those stages, but otherwise you cannot if it's a wet AMD. Now our next speaker is Dr. Dipendra. Dr. Dipendra V. Singh, who's practicing in Gurgaon. He's going to speak on cataract surgery with ERMs, how to deal with them, what's the double trouble he faces.
This is the last talk.
It's the last talk of the session. We are thankful to the
Thank you, Dr. Ashu.
Dr. Ashu, thank you so much. He has given a lot of inputs to us regarding the IOLs. He's an anterior segment surgeon in Delhi, and we are thankful to him. He has added a lot of how to deal with the intricacies in special lenses. Thank you so much, Dr. Ashu. Yes. Thank you so much. Thank you.
All of us are forever somewhere.
Yeah.
On to another session.
Now we have with us Dr. Dipender for his talk on apparietal membrane.
Yeah, thank you, Professor Manisha and AIOS committee for allowing us this session, invited one. And I'll be speaking on another double trouble, epiretinal membrane and cataract, and how do we take care of this in our practices. First of all, I went back and tried to find out that is this a common thing, that do you see ERMs in patients who have cataracts. So a lot of people have actually already started doing pre-operative OCTs for their cataracts. It initially started with premium IOLs because we all were promising a lot. So everybody wanted to have a good healthy macula before advocating a premium IOL. But then when everybody started doing it, they realized that there were a lot of macular problems which were missed in patients who were scheduled for cataract surgery. And this is just a couple of studies I am showing, but there are many studies available in literature. This one is from Poland, which found that when a good ophthalmologist has certified a normal fundus, they have said that this fundus is normal, and then on those patients when OCT was done, almost 12% had macular problems, with ERM one of the most common macular pathology. Similar study in Brazil have found around 7% incidence of macular issues in patients where macula looks normal on fundus examination. So that means that in our population of cataract surgery patients who are scheduled for cataract surgery, ERM and cataract is going to be a very frequent finding. In fact, when we discuss with my VR colleagues, we are often discussing that macular surgery is slowly becoming the most frequent surgery done by us. and I see Dr. Ashish nodding. So because I think we are detecting more, we are operating more and more cases, and this is a case almost 2 decades back we operated. You see idiopathic ERM improving nicely after surgery. All of you have seen these cases. And now we are operating other ERMs also associated with lamellar holes and LHEPs. So in general, I think what I would recommend everyone, because you will be doing OCTs for your cataract patients. So there are a lot of new terminologies which have been introduced based on OCT, and OCT has become a most important tool for detecting ERMs and categorizing ERMs, which one to operate and prognosticate how will they behave after surgery. So it would be a good idea to just get familiar with all those new terminologies and classification. I am not going to cover them, but just to share that there is a very good classification based on EIFL, which is known as ectopic inner foveal layer. This has come from Govito's group, and this is very useful, prognostically useful classification. I think you can just ask your retina colleagues to update you on this. Then there is a entity called ERM with lamellar macular hole, which Spade and all have very nicely described it. They behave differently from the top category of ERMs. Then there is a condition called LHEP, lamellar hole associated epiretinal proliferation, which are not good surgical candidates. And then one also has to differentiate whether it is an ERM or vitreomacular traction. So this is slowly going to become a basic information related to ERM, which all our even comprehensive colleagues should try to get familiar with. But the big question is, does ERM surgery is worth it? Many times, we have discussion with our patients and colleagues, and they often raise this question that you remove so many ERMs, is it worth it? So there are n number of studies available in literature which have shown that it's not only just metamorphopsia or near vision which improves, even quality of life and other functions also, they improve significantly after removing these ERMs. And there are n number of studies which have shown excellent visual gains, and I think all my VR colleagues will agree that this is one of the most gratifying and least risky surgeries out of all our vitreous surgeries. So, but again, we don't jump to surgery just because it is safe and it is visually gratifying. So whenever we encounter a patient with cataract and ERM both, we have 3 options. One is we just observe, don't do anything, and this actually applies to situation when both conditions are not qualifying for surgery. And if both conditions are qualifying for surgery, then combined surgery has huge advantage, and I'll come to that in the later part of this presentation. But then there are other considerations. If you are planning for a sequential surgery, you're planning to do cataract and then evaluate and then plan a VR surgery later on, that there are I think some issues related to that approach. One is, although it doesn't worsen frequently, but in vascular cases at least, there are chances that ERM or VMT might worsen after cataract surgery. Now this becomes a huge setback for a patient who has undergone cataract surgery and he has not achieved an optimal visual outcome. And of course there are financial and logistic disadvantages of doing a sequential surgery, which we all understand. So how do we decide that which are the good candidates for surgeries and which are poor candidates? So patients who are having idiopathic ERMs, I think, which are not associated with any other macular pathology, especially if they are symptomatic, and metamorphopsia is rated highest. I think if you have to ask a leading question from your patients, that do you see distorted? Ask most of the time we spend with these patients is asking about their reading habits, how they are reading, how much they are reading, and are they experiencing any distortion or broken letters, or is it just blurred near vision? And another thing, most of these ERM patients have a PVD, which pre-existing PVD, and they are also troubled by a floater, which can be sometimes really disturbing for these patients. So again, our threshold for surgery in these patients who are symptomatic would be much lower than asymptomatic patients. And of course, if you are following EIFL based classification, stage 2 and stage 3 are the ideal stages, I think, for surgery. And the poor candidates are if you have an associated degenerative disease like macular telangiectasia or neovascular AMD in ischemic retina, or if it is associated with uveitis, pars planitis. All these cases, I think we are not in hurry to operate, and we can always plan a sequential surgery, or we can just observe also. Similarly, advanced stage ERMs with total disorganization of inner retinal layers, what is called as stage 4 ERMs, they are also not good candidates for surgery. And this is just an example of ERM in a patient with uveitis and cataract. You can see this striation and significant ERM. I think this is also a very old case, and we were actually thinking of doing surgery for him, and he came back smiling, and you see vision improves, and I think there was a spontaneous PVD, and ERM just opens up. So but when we are counseling these patients, our main, because see, cataract, diagnosing a visually significant cataract is not a big deal for everybody. All of us we start doing it in our post graduation itself. The key question is how much disturbance ERM is creating. So we have to spend more time in that, evaluating history wise and clinically. And if you can have M charts, I think they are even better, but you can use your conventional Emsler grid to chart their metamorphopsia. But also don't go just by OCT picture. We see a lot of patients with significant ERMs, but they are reading 6/6 and 6 and no metamorphopsia. So we can't just go by OCT picture. Another patient, you see significant ERM, you can see significant ERM, but it is just temporal to fovea. OCT picture also dramatic, again reads 6/6 and 6 asymptomatic. So we will not do jump for surgery in these patients. But in general, our effort is to plan a combined surgery whenever indicated. And sometimes you will encounter a patient who has a very early cataract and early ERM. We don't mind following this patient serially and tell them we are not hurried to do any surgery for you. And we will, whenever we'll try to do it together, but let both pathologies earn surgery over due course. And if we see ERM with loss of outer retinal layers or any other signs of poor prognosis, anyway, we'll just plan only cataract surgery. We'll leave the ERM alone. And many of these patients have just cellophaning, and which is long standing. If you look into their old records, it has been mentioned 5 years back, 6 years back. They are non-progressive kind of ERMs. They can also be left alone, and you can just go ahead with the cataract surgery. And in general, if you have a significant cataract and a ERM, in our setup now, we'll rarely do this, that we'll do only ERM surgery and plan cataract later on, because we know a progression of cataract would be accelerated once we do vitrectomy. So that option is very less commonly used. And I think I'll just, I think that many times these patients have one eye which has been operated with a premium IUL and with a femto or conventional good surgery. Now once they are approaching us for fellow eye, you end up finding a ERM. So now, do you change your plan for cataract? Do you change your lens, or do you change your technology? We don't do it unless we feel that visual potential is limited, because many of them would improve to 6/6 and 6. So, and they don't have a progressive retinal pathology like we were discussing for DME or AMD. There is a strong case of avoiding a multifocal lens, because we know that these pathologies are there and they are going to progress. But ERM is something which I think once you remove it, many of them will be stable and they achieve good outcomes. So I think we often combine our conventional premium IUL surgeries with ERMs, and you can see you can just remove the ERM and ILM. This is just after removing the ERM. So message I wanted to give was that you need not change your plan for IUL in cases with ERM unless you see some reason for poor visual recovery, because many of them will achieve very good outcome. This is unlike other macular pathologies. And again, I think I'll just skip the surgery part. This was again a very significant ERM, and we did a combined surgery. And even with this amount of thick ERM, she recovered reasonably good vision. And you see stage 4 ERM also improving to 6/12. But this patient, we didn't go for a multifocal lens. We went for a monofocal lens. So what are the advantages of combined surgery? I think in these cases is one is logistic and financial advantage. You can always, reduce the cost when you are clubbing the surgeries, and you are actually combining two visually gratifying surgeries, so it amplifies the visual gains. And we have done our own analysis presented at IRSI quite a few years back, that there is no impact on refractive outcome when you do a combined surgery for macular pathologies, whether it is ERM or macular hole. Earlier there was a concern that if you are using optical biometry, ERM might induce some errors in measurement of axial length, but this was not the case, and which a lot of other colleagues all over the world have also published. So that concern that your biometry will fail you in patients with ERM doesn't hold true. And this is quite minimally invasive. The another advantage what you see when you are doing combined surgery is you get a very crystal clear posterior capsule, and so the view is very good. So technically also I think it's a good option to combine these surgeries rather than letting PCO. If you plan it after 3-4 months, you'll have some PCO and other issues coming up, and many times you can find additional posterior segment pathologies. You can address them when you are doing a combined surgery. So I think with this, I'll like to conclude. Number one thing is let's not miss ERMs when we are doing cataract surgeries. Incorporate good slit lamp biomicroscopy, and if possible OCTs for all your cataracts, so that you don't miss ERMs preoperatively, and get yourself familiarized with the biomarkers, which will help us decide good surgical candidates, and that helps in counseling also. And of course, goes without saying, don't get mesmerized by macula. Always look at the periphery. There can be additional pathologies. Many of them are secondary to pathologies in periphery, whether it is tears or vasculitis or other reasons. And of course, don't hold yourself back. If you see good visual potential, I think offer them a premium IUL and good surgeries, just like your routine patients. And of course, if both pathologies present very early, follow them serially, and I think give them an Amsler grid and tell them that you have an ERM which we might remove along with cataract. Yeah, so I'll conclude here. Thank you very much.
Thank you, Dr. Dipender. A very nice and a very comprehensive talk as always. But when I listen to your talk, I think we need to have a debate as to whether we should go in for a combined or a first cataract, and probably I am more in favor of going for cataract first, and then after 10-15 days the ERM. So since we do not have that much time, we'll have a debate sometime, and I'll be on the other
definitely.
side.
Yes.
But
sir, even if you put these and you put gas,
I can just add one line. When we are disclosing the session, in this session we were focused on cataract and macular pathologies where we can do something. So there is always an option to do this sequentially. But one good interest what we have in when we are managing these patients is to see the visual potential. That is why, besides that, the fact that there is a possibility that macular edema might worsen after cataract surgery, but more than that, you want to judge the best visual potential of these patients. That's why you operate cataract also when they are dry, even for AMD, so that when they recover and come back to you at 2 weeks post-op, you know how much visual potential they have. Your future strategy, especially for progressive diseases like neovascular AMD and DME, will depend on how much visual gain they have. And it's a definite setback for patients when you do a good cataract surgery and they have reading issues. And
just one last question, Dr. Dipender. What is, do you check for metamorphopsia or the visual acuity before deciding for going for ERM removal?
I think all three.
If visual acuity is, let's say, 6-9.
Metamorphopsia. Sometimes that's a very good question, that we have only 3 tools right now: Amsler grid or metamorphopsia, near vision, and OCT. So all 3 are pointing that ERM is significant and it is influencing the near vision. Then only you plan your surgery. That's how we do it.
Dr.
What is your, Dr. Ashish said, like you say, after 15 days you do the ERM surgery. What is your cutoff point for the visual acuity? The question you were asking.
Usually I don't operate when it is 6/9 or 6/6. I don't operate.
Post-operative.
6/9 or I mean, if it is 6 by 12, 6 by 18, then only I operate.
Thank you, sir.
Do you have time for it?
And we are running short of time already, but if you have important question, you can ask shortly.
Situation both the three retina people over here. Patient, nucleus sclerosis, N3, N3 and 4. No PSC, nothing. Improving to, let's say, 6 by 12 partial or maybe 618 on 612 partial. N6, 612 partial distance, N6 with epiretinal membrane. What would you do?
I think first do the cataract surgery and then assess the situation after 2 weeks, then you can plan it out. I think
One thing for the take-home message is that near vision,
Yes.
if it is improving to N6 or N6 partially with N9, indicates that the macula may not be so badly off. Cataract is the primary
Absolutely.
culprit, yeah.
Absolutely. Discussion.
I would like to thank the Dr. Partha Biswas and the scientific team for giving us an opportunity. Also, Dr. Manisha in coordinating with this instructional course. My understanding of the double trouble was not related to only the diabetes and cataract. It's the general double trouble on the table managing in the operation theater. So the contents will go like this. So the iatrogenic complications or the advances in medicine have led to more sophisticated methods of diagnosing, treating, and monitoring the patients. Net effect is an improvement in the care, but it itself is evident that minimizing iatrogenic complications will increase the benefit to the patients of ever-increasing complex method of treatment. Iatrogenic complications tend to be sporadic and varied in nature and are difficult to study as a group. Psychological and medico-legal problems add to this difficulty. The main impact of iatrogenic complications is on the patient, who may be temporarily or permanently disabled or even lose his life. The different structures involved in the involvement of the surgeries and on the different parts of the eyes. Coming to the cataract surgery, the first one, giving the anesthetic complications like blocks in peribulbar and retrobulbar blocks. The retrobulbar hemorrhage is one of the most important complications, especially in the hands of the learning residents. So on the table it may be presented as a sudden proptosis, chemosis, and RAPD. And the management goes like the IV mannitol has to be given, the urgent cantholysis, postpone the surgeries if possible, and orbitotomy if required, if it is present for more than 6 to 8 hours. Coming to the globe perforation, again one of the dreaded complications of anesthesia, and thanks to the topical surgeries and the subtenos injections, and on the table it can be identified as a severe pain response, sudden increase in the intraocular pressure or severe hypertony, corneal clouding, changes in the ocular red reflex, sudden loss of vision, visible enlargement of the eyeball, that is prominence of the eyeball, and a popping sound. And if they are there, you have to suspect of your globe perforation. And management will be, most of the time it is observation, and if it is quite serious, then you have to take a vitreoretinal consultation and the symptomatic treatment has to be done. This is a subtenous block. I'll just skip this thing. Then coming to the phacoemulsification, the common the complications are trouble on the table or the wound leak if it is not properly done. So the prevention could be by doing a correct triplanar incision has to be into practice. And PC rent, if many things are not taken care, if you have to study the cataract in advance only before you take it for a cataract surgery, and certain maneuvers have to be avoided in case of certain conditions, like in case of a posterior capsular posterior polar cataract, you have to avoid the hydrodissection, etc. And this has to be prevented in case of PC rents. And nucleus drop has to be taken care, and that will be in case of especially in learners, it has to be taken care. And if there is a nucleus drop, it has to be managed very efficiently on the table. And if it's very good, if there is a vitreoretinal services available with a cataract surgeon, you can hand it over to the vitreoretinal surgeon. If not, the attempts have to be made to retrieve the nucleus from this thing by using either the perfluorocarbon gases or by using the vectis to lift the nucleus, or even by using your viscoelastic substance also. And if a vitreoretinal consult is there, call him and give it to the hands of vitreoretinal surgeon. And in case of squint surgery, the common complications which are troubling on the table are the oculocardiac reflex. This is because of the stimulation of the baroreceptors in the these extraocular muscles. If they are handled inadvertently, they can lead to the vasovagal attack, and the patient may collapse on the table with hypotension and bradycardia, and that has to be taken care. And it has to be that is by meticulous use of these muscle hooks and handling this the extraocular muscles. And if it is possible to give beforehand atropine injection, that will prevent the vasovagal attack and oculocardiac reflexes. And the scleral perforation, especially in case of the squint surgeons, the needles have to be placed very properly. Instead of 90-degree perpendicular in this thing, they have to be pierced in a very obtuse angle, and they have to be avoided. And in case of lost muscles, in case of extraocular muscle surgeries, the stay suture has to be given before you cut the tendons, and otherwise you may lose the muscle, and it will be very difficult on the table, and you may end up doing a lot of things there. Okay, and we end up even doing orbidotomy to trace the muscle. And in case of the refractive surgery like LASIK, the free caps, there are common complications. So the prevention can be done by the corneal markings, the double circles, etc. And this video is not playing. And the prevention can be done by proper docking of the keratome, and proper vacuum, and periodic servicing of these machines. And there has to be an eye bank support if they are doing a cataract, the refractive surgery, if the flap is lost and you have to take a button from the cornus donia. And buttonhole flaps, and corneal perforations, and decentration of the flaps. And even in smile surgeries, the decentration of the lenticule, lost lenticule, and tear in the incision, they can take place, and the prevention has to be done. And in case of keratoplasty, penetrative keratoplasty, expelled succeroid helminth, you can anticipate the risk factors like uncontrolled hypertension, very high IOP. Prevention can be done by identifying the risk factors and treating them. And paracentesis and AC entry, IV mannitol, and surgery under general anesthesia, they are advocatable. And in case of retinal surgery, you have ocular ischemic syndromes, can be prevented by choosing the proper sized plunge and this thing. Avoid the wider sized enclosure glasses, and also avoid the veins which we can compress and lead into ocular ischemic syndrome. The retinal detachments can cause in case of ILM peelings, intraocular foreign body removal, and also in case of PVD inductions.
So please summarize.
So yes, that's done. And retinal tear can also take place, and can be prevented by using proper perfluorocarbon gases and silicone oil, and lasers can be used. Retinal bleeding and ocular air embolism, also very rare and remote complication, has to be thought and kept into the mind, and it has to be prevented by proper use of gases, etc.
Sir, time is
And
over.
ocular hypotony, phototoxicity can be avoided by using proper chandler instead of focal light. Thank you very much for the patient hearing. I know it's time for lunch.
No, actually the other session is getting late.
Yes, thank you so much.
Thank you so much.
Thank you, sir. Thank you for the comprehensive talk.